How's it going, guys? We have a pass level question for pulmonary for step 1 internal medicine TCK. Before we get started, please subscribe to my channel. I really appreciate it. Give me a like. Really appreciate it. Find me on Instagram, mehlman_medical, mehl_man_medical, links down below. Find me on Telegram, links to the Telegram channel down below. And I'll start the clip. 40-year-old man with HIV. He's got a 3-day history of worsening cough and fever, temperature 101 Fahrenheit. Physical examination shows dullness and percussion of the right lower lobe. Current medications are zidovudine, didanosine, ritonavir, trimethoprim-sulfamethoxazole, which the following is most likely diagnosed as. So this combination of zidovudine, didanosine, or ritonavir, this is just heart therapy, highly active antiretroviral therapy. Zidovudine, didanosine, both NRTIs, ritonavir, protease inhibitor. Focus of the question is not this, but I'm just saying you know what these drugs are. Trimethoprim-sulfamethoxazole. I'll talk about this as we move through the question. So choice A, typical bacterial species, wrong fucking answer. Could obviously refer to Mycoplasma, Legionella, Chlamydia. So Mycoplasma, Legionella, Chlamydia, obviously they are technically considered gram-negatives, but they have deficient peptidoglycan in their cell walls, so you cannot use beta-lactams against them. That's why they're known as atypicals. Okay, they have absent peptidoglycan in their cell walls, and Mycoplasma, Legionella, Chlamydia are classically going to use azithromycin. All right, so Mycoplasma, walking pneumonia, bilateral interstitial infiltrates. That's just an otherwise young, healthy patient who has a bad chest x-ray, low-grade fever, and a dry cough classically. And it can cause cold agglutinins, okay? So low hemoglobin. I've harped on this in my other YouTube clips. They do pneumonia bilaterally, and it's got hemoglobin of 10 or 11. That's slightly low hemoglobin. Then you're going to have cold agglutinins. That's what's causing that. That's mycoplasma, okay? Legionella can cause hyponatremia and diarrhea. Chlamydia pneumoniae, USMLE doesn't give a fuck about. Chlamydia trachomatis pneumonia, the actual STD, D through K, can be seen in neonates where the neonate will have conjunctivitis initially, and then that will drain the nasolacrimal duct, ultimately leading to a chlamydia pneumonia. Wrong fucking answer. Choice B, gram-negative diplococcus, wrong fucking answer. This would refer to Neisseria, meningitis, gonorrhea. Okay, could do a 17-minute discussion of all the details. Don't really want to get into that stuff. Obviously, Neisseria meningitis can give you a non-blanching rash in addition to meningitis. Okay, it's bacterial, so you're going to have low glucose, high protein, high neutrophils in the CSF, and you're going to empirically treat meningitis with vancomycin, ceftriaxone. For gonorrhea, obviously you're going to give IM ceftriaxone. You're going to co-treat also for chlamydia, which is going to be oral azithromycin or doxycycline. There's a lot we can talk about. Point is, wrong fucking answer. Choice C, gram-positive diplococcus, correct answer, refers to strep pneumo. Now, there's 2 points you need to know here. It's pass level, as I said. So the first point is they give you dullness percussion of the right lower lobe. So when we have a lobar pneumonia, immunocompetent or compromised, doesn't matter, strep pneumo until proven otherwise, okay? So the quote-unquote tricky nature of this question, it's pass level as I said, but it can be a little bit tricky if you're first seeing this, is when we have an HIV patient, I didn't give you the CD4 count under 200, but the fact that this patient's on trimethoprim-sulfamethoxazole, we know right away the CD4 count must be under 200. So this is the prophylaxis for pneumocystis already. Okay, so you know it can't fucking be pneumocystis. That's one point. A second point is that pneumocystis is going to be bilateral ground glass pneumonia. It's not a lobar pneumonia. So I didn't even have to tell you the medications here. This made it easier. The fact that he's already on TMP-SMX, you know it's not pneumocystis, that made it easier. They do that sometimes. But here we clearly just have a lobar pneumonia. And you need to know that they'll just say straight up, there's a lobar pneumonia, answer is strep pneumo. Student chooses pneumocystis, it's the wrong fucking answer, okay? So pneumocystis, as I said, it's a bilateral pneumonia, ground glass. They can show you a stain where it'll be oval-shaped yeast, okay? Silver stain, and you do bronchoalveolar lavage to diagnose pneumocystis, but TMP-SMX is both the prophylaxis and treatment for pneumocystis. For strep pneumo, we're gonna treat it with azithromycin. Same as with the atypicals, okay? It's the empiric treatment for community-acquired pneumonia. So real quick, let's just hop through their other answer choice. Virus, wrong fucking answer. And obviously just community viral infection. Could be rhinovirus descending to the lungs. in immunocompromised, you could think of CMV pneumonia. I've seen that on nbme. So it could be organ transplant recipient blood transfusions or HIV. So they can show you the alloy appearance on pulmonary biopsy, and then the answer is ganciclovir. Okay, that's how you treat CMV. So it's a DNA polymerase inhibitor, causes chain termination and resistance to ganciclovir. Same as with herpes with acyclovir. It's going to be alter or absent viral thymidine kinase. Wrong fucking answer. You know the deal. I'm to make more content. If you like my stuff, subscribe to my channel. Appreciate your time. That's it.